name has changed. It used to be called non-accidental injury, and now we call it suspected physical abuse. Um, and in terms of deciding whether we image children with suspected physical abuse, we tend to leave that to the pediatricians to decide whether they should image children because they are the people who really interact with the parents. And if they are at all suspicious, we generally go with it with them. So now I was hoping I might be able to do next slide. Let me see. Is that going to work? That works. Yeah, great. Okay. So physical abuse is actually quite prevalent, much more prevalent than we think. We know that across the world we underdiagnose it. We don't want to think that this is happening, but there are many families that are in trouble, and actually quite a lot of children are abused. In the UK, we find that 65% of our children who are taken away from their parents for one reason, taken into care, foster care, or a children's home, that's due to abuse or neglect. And actually, the number is increasing. Um, and the outcomes are very poor, even from quite small babies. These have very bad longer term outcomes, abusing babies. 45% of babies who have been abused end up with mental health disorders, and they're 5 to 10 more likely to have special educational needs. So it's really quite common. This is, it's really quite a bad problem. So this is a very old slide from 1997, but it still bears true. And what it's looking at is the relationship between child maltreatment and the various negative outcomes during adolescence. So, in the darker bar, it shows you that the maltreated youth, the ones that have been physically abused, that's the dark one, and the lighter one is just children that haven't been abused. And you can see that if you look at what they used to call delinquency, I mean, being in trouble, basically, being violent is really common. I mean, the reason some of these levels of violence are so high is because these are all children from a matched socioeconomic group. So these are all children who are deprived one way and another anyway. So they have fairly bad outcomes. But within those children with bad outcomes, actually, physical abuse makes things much worse. So it's a really serious societal problem, actually, and it doesn't just end when the abuse stops. So, as radiologists, probably the commonest way in which we come across physical abuse is when we're looking at fractures. And fractures in non-mobile infants. So the level of the baby's mobility is really, really important. So fractures in non-mobile infants are really, really rare. And by that I mean crawling as well, actually. I mean, children can injure themselves when they run, when they fall, when they walk sometimes, but they have to be quite mobile before they start getting fractures. I'm going to start looking, these fractures that I'm going to consider today are rib fractures, metaphyseal fractures, long bone fractures, and I will maybe say a little bit about skull fractures, but not much. Um, so why is this important? Um, because, let me just move that. So let me tell you this story. This baby was 2 or 3 months, yeah, 2 months, and they presented to a hospital not far away from where I work. And the question was sepsis. The child was a bit chesty and, generally not very well, a bit miserable. So the child had this chest X-ray, which was viewed by the pediatrician in A&E, and he was thought to have a chest infection and sent home. In fact, this chest X-ray was also sent to a teleradiology company, which actually reported the film as normal. Um, but in fact, you can see here where the arrows are. These ribs are very lumpy. This child has multiple rib fractures. I'm not actually pointing them out, all of them, but there are multiple rib fractures all over. Now, so this child has been abused, and these are healing rib fractures. So these are at least 10 days old. So the child has been abused from quite a young age. If we look back, the child presented to the emergency department 10 days before, 11 days before. And this again is kind of not that uncommon. Children who keep presenting to healthcare services, these families are actually looking for help, but sometimes they can't quite tell you what that help is that they're looking for. You can see there that although we can't see these great big lumpy rib fractures, there is an acute rib fracture where the arrow is there with no callus around it. You can't see the rib fractures on the other side, though I'm sure they were there at that stage, because what you can see is a tiny little bit of pleural fluid there. So the rib fractures are not visible at first, very rarely. I mean, it's quite unusual to see an acute rib fracture. So I'm going to talk about this later about why it's important to do follow-up films, because particularly with rib fractures, you may not see them on the initial film, and they're very hard to detect clinically. Now, the tragedy of this is that a couple of days later, this child then presented with this head injury. In fact, this is a post-operative film, but you can see the widespread ischemic damage. That was after they'd had their subdural drained. You know, that was a really severe, life-changing head injury. And they also had this cervical spine fracture there of C4, a crush fracture of the cervical spine. And of course, the tragedy is if somebody had noticed, I mean, the first film is very, very difficult with just that little bit of pleural fluid and that acute rib fracture. You'd really have to be looking for those. But if somebody noticed those rib fractures, on the second film, that child would not have gone home. This injury would have been prevented. And so, uh, and actually, the fractures were missed by the radiologist as well as by the pediatrician. So we do see these fractures missed very often, and it's really important not to. I can't stress enough how important it is to pick these up. So what should have happened here is that this child should have had the skeletal survey. Now, the skeletal survey consists of these x-rays, three chest x-rays, lateral spine, pelvis and both femora, both legs, both arms, both forearms. I haven't actually fitted them all on here, but your hands and feet. So I haven't fitted them all on. So there's about 23 x-rays often. And the radiographic technique is really, really important. If you want to know about these and you want to make sure that you're doing the right views, it's all listed here in this quite short document, the radiological investigation of suspected physical abuse in children. Now, that's an RCR and Society and College of Radiographers, and also RCPCH, Royal College of Pediatrics and Child Health. So that's joint college guidance, and you can find that on our website. So mainly we use plain films. Nearly always we use plain films, but just sometimes these days we use CT. CT's got a lot better, as you know. I mean, the images are better. It's so much quicker. So whereas previously the time it took was a problem for little infants, you can quite often with babies just feed them, wrap them up and put them in the CT scan, and you can get them to lie still for the CT. Particularly as in if you're looking at the bones, you don't really need to use contrast. And sometimes it's a really good decider. It also now, if you're using proper pediatric protocols, the dose is much lower. So here's a case in which we use CT. You may be able to see on this oblique chest X-ray that there is just a slight expansion of the back end of that rib. So you can see it here on a close-up view. Now, that expansion could be a fracture or it could just be a normal variant. And that was the only thing on this child's skeletal survey. So these are big decisions. If you say that's a fracture, this child is taken away from their parents and court proceedings are started. If you say it's not a fracture, the child goes back to their parents. And if you're wrong, as you've seen from the first case, that could have really serious consequences, putting a child back into an abusive environment. So, they're big decisions. And for me, what I want with a big decision is certainty. So we quite often, in this case, would use a CT. Now, here's the CT. And what that shows is here at the back, quite an obvious rib fracture, healing rib fracture. So now that's what we have. We've got certainty. We know that this child has got a rib fracture in this position, which I'll go on to talk a little bit more about later, but that is pathognomonic of abuse. Well, almost, not quite, but nearly, unless there's an explanation. This means the child is abused. You can be certain. So rib fractures are caused by compression of the chest. And those ones at the back, those costovertebral junction fractures, require AP compression. So what I mean by that is they require compression from both sides, bimanual compression, so squeezing of the baby. So that's what I mean. You see the position there of the way they're holding the baby. And then that's sometimes accompanied by shaking, giving you a head injury, as you can see there with the head flopping backwards and forwards. So this is just a diagram of a rib cage, and on the one on the left, you can see that those are the positions where you may be particularly likely to get fractures. But actually, from compression of the chest, you can get fractures anywhere around this arc, anywhere around the rib can occur from the same episode of compression. And I want to draw your attention to the ones at the back, to the articulation of the transverse process with the rib there, what we call costovertebral junction fractures. And that's the same fracture as we saw on the last CT. Now, in order to get that, those are caused by leverage of the transverse process against the rib, as you see in that diagram there. And you can see on the left diagram that, that's the normal relationship, but as the spine is pushed in towards the sternum, there's leverage of that rib over the transverse process, and that's what causes the fracture. Now, in order to do that, you have to have movement of the spine relative to the ribs. And what I mean by that is if you were to just drop a television on a child, say, and the spine and the posterior ribs were to stay in line, actually that would not result in leverage at that position. And that would not give you costovertebral junction fractures. So that fracture is caused by pushing the spine in towards the ribs. And you could only really do that when you've got two hands around a baby. So that's why those ones are so specific. This, on the other hand, where a baby's thrown up into the air and caught, does not give rise to rib fractures. I can't exactly recommend this as a practice, but honestly, this guy is just loving it, isn't he? He is having a great time. No way is somebody fracturing his ribs. So, rib fractures caused by compression, ones at the back require AP compression. Can they happen as a result of cardiopulmonary resuscitation? They do happen actually, but we very rarely see them on chest x-rays, and they very, very rarely happen at the back. If they do get them, they're really at the costovertebral junction, sorry, costochondral junction at the front. So that's where they normally happen, and you very rarely can see those on x-ray at all. So we used to say that rib fractures didn't happen with CPR. They do, but not to be confused with physical abuse, so don't worry about that. Birth trauma, again, birth trauma is a very unusual cause. I mean, it's not impossible, but it's a very unusual cause of rib fractures. And one review found only 13 cases in the world literature, and those are all large babies with most of them had shoulder dystocia as well. So you don't really get rib fractures from just a normal delivery of a normal sized baby or a cesarean section. So it's usually a difficult instrumental. So do you ever get them accidentally? Well, in a non-mobile baby, they are extremely rare. They're associated with major trauma. When you do get them, there's usually multiple life-threatening other injuries as well, and a mortality rate of 40% associated with them. I mean, that's not because of the rib fractures, that's because of the other injuries. So they're pretty serious when you get them. And that's because babies' rib cages are really, really flexible, are really much bendier than an adult's bones, and they don't fracture very easily. Here's one that I came across that I knew, one of our cases. The child was in the seat belt with the mother. The mother was sitting in the front seat. The other smaller children were in the back seat. So she was a front seat passenger, and the baby was down on the lap belt part, the cross belt part with her. So in the same belt as the mother. The father was drunk and drove into a wall, and so the baby was then squashed between the belt and the mother as the mother careered forward. So you can see at the side there are some rib fractures. So this was a big, big accident. This is a head-on collision and a lot of trauma. This is the sort of trauma that causes rib fractures. In fact, there's another two at the side, but you can't really see those very well. It's not a very good film. Um, Also, interestingly, the child had these two little fractures of their humerus as well, where the humerus had got caught in the belt. So that's the sort of trauma what we were talking about that causes rib fractures. It's not, falling off a sofa or the dog stood on them or the toddler fell on them. Those are all explanations you get. Those incidents do not cause rib fractures. It's a motor accident that causes rib fractures if it's accidental. So I'm going to move on now to metaphyseal fractures. These are also known as classic metaphyseal lesions. There's a guy called Paul Kleinman who wrote an awful lot about this, done a great deal of research into abused infants. He's American, and really good book that he's written about this, and he coined this term, classic metaphyseal lesions. These are highly, highly specific, like rib fractures for non-accidental injury or physical abuse, whatever you call it. They're very rare over 12 months. They're often multiple and commonest in the lowest limbs. Experimentally, you cause them by pulling or twisting and pulling. Those are experiments in baby piglets. But possibly it's thought that maybe a whiplash effect when a baby's shaken can cause these, because they are sometimes seen in association with a head injury and rib fractures. So it's thought that maybe as the limbs flail around if a child is shaken, that those can give that same sort of pulling, twisting mechanism and give you metaphyseal fractures. So they do occasionally occur accidentally. So they have been known to occur during breech delivery or cesarean birth. And these are usually when you've got a great big beefy obstetrician who's really desperately trying to get the baby out, or a midwife. As you know, childbirth can be a tricky business, and there are times when people need to get that baby out as quickly as possible, and sometimes they pull very hard indeed, and sometimes that can cause metaphyseal injuries. They have been described in a French paper when somebody was doing physiotherapy for club feet, where they were really pushing, and twisting the legs around and then putting plaster casts on in order to try and straighten the feet. So I think, again, a lot of force. And then, as I've mentioned, in piglets, they're caused by pulling and twisting. Now, because of where they are, they can actually appear very different depending on the angle of the X-ray. On the left-hand image there, you can see that this is the point of the metaphyseal injury. Now, it occurs at this point in this age because babies, when they're very little, you're under 6 months, they are growing at a much faster rate than at any other time in their life. And this bit of the bone, the metaphysis there, is laying down cartilage and laying down matrix as quickly as it can. And the bone is taking a while to catch up. So it's not calcified. The matrix is softer, is more is easier to fracture, and it hasn't yet been fully ossified. And so that area is particularly vulnerable in these babies because of the rapid growth that they have. You see there that in that diagram that some of it's calcified and some of it remains cartilaginous. So although the fracture itself probably goes through the whole of the bone, there's only part of it that is actually calcified. So that's the only bit you see on the X-ray. And so you can see there that depending on how the X-ray strikes the bone, so you can actually see a complete ring or maybe just a corner, depending on depending on the angle of the X-ray. So if you're in any doubt, you can take focused views, and that'll give you a better view or a different view. So that's what they're all about. And they can be really difficult to see. The worst thing about metaphyseal fractures is trying to decide whether or not they're present. So here's one, quite a good X-ray. I mean, it's very magnified here, so it looks a bit sort of mottly, but it's not a bad X-ray. And you can see that there's a tiny kind of, ooh, what's that? The lateral medial aspect of the ankle. So thing to do then, take another view. Okay, so we've got a lateral here, and you see with the blue mark there, you can see the wonderful, well, it's not wonderful, but what I mean is you can see wonderfully well the corner fracture there, and that is definitely a fracture of a metaphyseal fracture there. As they get older, they become more obvious. So, or can become more obvious. So they heal in multiple different ways, but it's the change in them. If you're unsure, it's the change in them that can really help you. So that's why when we do an X-ray, when we do skeletal surveys, we do one survey and then we do another follow-up in 10 days, because that can be really, really helpful. So just coming back to that, actually, something I should have said earlier, I mentioned before that rib fractures may not be seen on the acute image. So another reason to do the follow-up at 10 days is because the child may have rib fractures, but you can't see them. So even if the initial chest X-ray is completely normal, the initial skeletal survey is completely normal, you do need to do a follow-up film because other injuries may turn up. You do need to do the follow-up survey, because you can't be sure until you've done both. Okay, so here is a metaphyseal fracture. I think you can probably see that, just see that very faint line at the bottom of the femoral metaphysis on the left-hand side. But then a few days later, you can see that it looks much bigger than it did before. So that is at 13 days. And you see the fracture has become more obvious. And that's because there is more bone laid down on that. And so it's apparently, it's not a bigger fracture, but it's just healing in that way. And as I mentioned, they can heal in all sorts of different ways. So this child has actually got 3 metaphyseal fractures, or 3 areas we thought metaphyseal fractures on the initial skeletal survey. So you can see one at the bottom of the femur there. You can see one at the bottom of the tibia. Now, those are quite obvious. They're sort of corner fractures. But there's a bit at the top of the tibia there, which I'm not sure whether that's abnormal or not. It's just a bit sort of funny looking. So there they are in close up. You can see the corner fractures and then the funny little area at the top of the tibia there, which we're not quite sure what it is. So then we're going to follow those films up. At 2 weeks, you can see that the fracture at the top of the tibia is really obvious now, and it's got periosteal reaction going down the side. They don't always heal with periosteal reaction, in fact, quite often not. But that is really healed. And we didn't think that looked like much, did we, to start with? But it really does now. The one at the bottom of the tibia has also got a little bit bigger and is obvious and is changing. So you can tell that it's a fracture because it's changing. The one at the top of the femur has gone completely. It's completely healed, and that is not unusual. The fact that it's not there on this follow-up film doesn't mean that it wasn't a fracture. In fact, quite the reverse. The fact that it was there on the initial one and now isn't confirms the fact that it was a fracture. So it's very important to do these follow-ups. You can see that's a close-up of the tibia there, and you can see that periosteal reaction down the back. And close-ups there of all the other ones. So these are all ways, this is from Paul Kleinman's book, this is not my image, but these are all ways in which metaphyseal fractures can heal. And they give you all these funny appearances. I've shown you some of these corner fractures here, and I've shown you some of the ones with the sort of band underneath. There are some there where there's just a lucent band at the end, and that's a sign of a healing fracture. And also bottom right, you can see like a little notch, and that's a sign of a healing metaphyseal fracture. So there are all sorts of different ways in which these can present, and they can be really difficult because it's a tiny, tiny thing to make a very big decision on. And, so give yourself the best possible chance to see them. If you do the longer views and you're not sure, do a coned view. Do a coned AP and lateral of that um, knee or ankle or whatever, just to give yourself a better view. Because as we saw earlier, the direction of the beam can make all the difference in the visibility of these fractures. And always do the follow-up, and any change is likely to make you feel more confident. There are some things that are confusing though, and one of them is the subperiosteal bone collar. And this is really common around the knee. Here's one on the fibula. You can see that there's a kind of step off on the lateral aspect of the fibula there. You can see that very straight line and then it steps in. That is a subperiosteal bone collar. That's a normal anatomical feature. You see it at the knee and also sometimes at the wrist. And if you don't get good images, it can be difficult to tell. Here's one on the medial aspect of the tibia. Now you can see that there's a funny little thing on the medial aspect. And you remember previously we saw one a bit like that, and it turned out to be a horrible fracture. So, I wasn't sure about that. But then we did a better film. You notice that that film, the leg is a bit bent. In this one, we did a better cone film with a leg completely straight. And on that one, I think you can see that that it's really straight, that aspect on the medial aspect of the tibia. Can you see that? It's really straight like that. And that is a subperiosteal bone collar. That is a normal variant and it's not a fracture. Toddlers can also be difficult. As I've mentioned, metaphyseal fractures occur in really young babies. So usually less than 6 months, always less than a year. They really don't occur in toddlers. This is one that we found very difficult when we were young and naive. But in fact, Paul Kleinman, again in his book, has detailed all of this. You see the bit on the medial aspect of the distal femur there is a bit sort of fluffy looking. And we thought, oh, maybe that's a fracture. So we took some more films, that bit there. We took some more films and we did this oblique. And gosh, that looked dreadful. It looks awful. I mean, that really looks like some chunk of bone has come off. But actually, that's a normal variant in toddlers. And so don't worry about that. There are images. That is a normal variant. Here's another case that we found very difficult. Um, well, um, they found difficult, I think is safe to say. So this child came into the emergency department not moving their arm. I think they're about 2 or 3 months old, not moving their arm, and their arm's very swollen. I don't know if you can see in the soft tissues there that there is some edema in the soft tissues. Those fat planes are not really clear. And on the medial aspect of the proximal humerus there, you can see a periosteal reaction there. And so the child was admitted, and I didn't see this film until the following morning. This was another X-ray that was taken in A&E. And again, it's a really poor quality X-ray. Radiographers are often very anxious about taking X-rays of children, because particularly if they're in pain. You can see on this one that there is soft tissue swelling, but there's no decent alignment of the humerus or the forearm. But actually, the sharp-eyed amongst you will see that the radial head there is hard to tell actually which is the radial head, but you can tell that which direction it's pointing. It's not pointing at the capitellum. And as I'm sure you know, that the radial head should always point at the capitellum, no matter what projection or what position the elbow is. If the radial head is not pointing at the capitellum, then there is a dislocation of the radial head. And so that is really important. So the child had an MRI the next day, and they had a general anesthetic MRI. You can see all this soft tissue around there. This looks like a horrible injury. And actually, it's quite a long way away from the periosteal reaction that initially alerted us. Then if you look at the lateral, what you can actually see here is that the distal part, the whole of the epiphysis of the humerus is pulled off. So that is like a more severe metaphyseal fracture. That is an epiphyseal dislocation. Now, these are strongly associated with abuse. the other time that they do occur is sometimes as birth injuries, but they're really, really strongly associated with abuse, and they're very hard to treat. They often don't heal very well because the blood supply is quite poor. So here is the same baby who then went on to have a skeletal survey. Now you see that actually when they took a decent AP, it's completely obvious there that the elbow's dislocated, completely obvious. And then when we do the lateral, not only do you see the radial head not pointing in the right direction, but you see the this little fracture at the back there. So, if we'd taken decent films it would have been obvious what the problem was. Here's another one. This child came in just pale and unwell, 4 months old. Had this chest X-ray taken, which is a bit odd looking. There is emphysema here within the mediastinum in a funny place. It's not like a normal pneumomediastinum, but there is air in the mediastinum, and some of that's tracking up to the neck, actually. The child went on to have a CT, and one of the things that you can see here is, there was lots of air. You can see the funny bits. There's an NG tube going down the middle, and on either side of that, there's air. And there's also air in the superior mediastinum as well. So it's all looking very, very odd. But one of the things you can see there is that the nasogastric tube doesn't quite reach the stomach. It approaches the stomach, but it doesn't go into it. I mean, is that just that it's too short, or is it in the wrong place? The child wouldn't drink, and so we then did an upper GI contrast study. And what you can see here is the contrast. This is a lateral view. This where the front arrow is, that's the trachea. Sorry, that's the esophagus in the front. And at the back there, all of that contrast is in the mediastinum. So that's a ruptured posterior esophagus. And the child, that's from having a bottle pushed forcibly into their mouth, and they've ruptured the back of their esophagus. So that is a really, really severe injury, and not very common, but really horrible. This is another little baby who was obviously unwell, had bruising on their abdomen, had this CT scan, and you can see that there's a lot of fluid in the abdomen, and also this really severe liver injury. And of course, the key is you see that fat rib at the side there, which shows a healing rib fracture. When we looked on the bone windows, we could see rib fractures here and here. Now, those are refractures because the fracture runs through the callus. So the fracture, so that rib has been fractured once, started to heal, and then fractured again, those two ribs. And also there's an acute fracture there. So these are fractures of differing ages. And this is actually, this is a very severe and horrible case of abuse. Moving on now to see whether, I mean, are there cases when it's not abuse? I've thoroughly depressed you, I'm sure. But yes, sometimes, and it can be really difficult to work out when, there's something else going on. So here's one, and you need to think about this. Here's a child that's had a fractured tibia. They're a toddler, and you can see that fracture there, but you can also see that the bones look a bit thin, and there's a very poor, the cortex is quite thin as well, and generally they don't look very white. So you look at that femur and you see, again, thin cortices doesn't look very white. The key is when they had their skeletal survey, on this Towns view, you can see that they've got multiple Wormian bones. Now, that is a case of osteogenesis imperfecta, and they quite often present with fractures. This is the more common form of Wormian bones, which are mosaic Wormian bones. It's really hard to see, it's really hard to show this, but there is you can see a sort of filigree of Wormian bones there. I've magnified it up for you. It's a really funny appearance, but that is classical for osteogenesis imperfecta. So how to tell whether it's osteogenesis imperfecta or abuse? Well, it does honestly present at a different time. Very frequently, there's a family history. You often see osteopenia or wormy in bones. So, most of them you get like that. The fractures occur at a different time. The fractures don't occur in non-mobile babies. They start to get fractures when they start to walk. There is a subtype that may have no positive features, no blue scleri, no nothing like that, and that can cause confusion. Um, Genetics can help you, but it's expensive and time consuming, so you don't normally get to that. But some of the difficult times that I have in court are about whether or not the child has osteogenesis imperfecta. Usually not. Usually, if the child is not mobile, it's nearly always abuse. Another problem we're seeing more and more frequently is metabolic bone disease at prematurity. Um, that's in children, that occurs in children who are less than 28 weeks gestation, because in the last third of pregnancy, that's when you get the majority of mineralization of your bone. They're usually less than 1.5 kilograms. Often they've had medication and parenteral nutrition. They haven't been moved because they're really fragile, chronic lung disease, antacids, all sorts of things predisposed to it. Um, it can be difficult though. Usually the bones look really, really abnormal, really abnormal. So this child is now 3 months old. They were born at 24 weeks. So they're very premature. They were tiny. They were absolutely tiny. And you can see they're still pretty sick. They're being ventilated on intensive care, 3 months of age. And the bones are really thin and weedy. You can tell just by looking at them, the bones aren't normal. Well, they have rib fractures here. Oh, sorry. They have rib fractures, plenty of them. We actually often miss them because you're often looking at all the other things that are going on the chest X-ray and they develop very slowly. But it can be difficult. When they're like this, you know then that the child is, this is because of their poor bones, not because somebody's abusing them, because these babies' bones fracture just with normal handling. But they do tend to present quite late, so sometimes they present at 3 months, and sometimes the child has even gone home from hospital. And in those cases, it can be quite difficult, particularly if the bones don't look particularly abnormal. But usually they do look very abnormal. So always ask about a history of prematurity as well. That's really important. Good resources for thinking about this, child protection portal at the Royal College of Paediatrics and Child Health. You can get this stuff free of charge. It has systematic reviews and tells you about bruising and things like that. Um, so if you're in doubt, use CT for rib fractures. Classic metaphyseal lesions are complex and difficult, but follow-up is extremely helpful. Know about the normal variants. Ask yourself whether the bones are normal. That every time you need to do that. Usually they are, but you need to do that. And visceral injury is pretty uncommon, but you can't really detect it any other way than with imaging. So the quality of imaging and the interpretation is key. So here, this is the radiological investigation of suspected physical abuse. That tells you a lot. It also tells you a lot about head injuries, which I haven't covered today. This is also quite helpful, the major pediatric radiology, trauma radiology guidance, which is new out this year or last year, which tells you about managing major trauma and imaging major trauma in babies. Thank you.
Thank you very much. Uh, so if there are any questions, please, you can put in the chat.
Oh, you're a great audience. I love it. Oh,
Any role of
isotopes. Good,
isotope?
good question. Very good question. So, no, not really. And I'll tell you why. Because you're looking at the metaphyses, which are hot in babies anyway on isotope scans. The other thing is, most of us really fail to get isotopes of the highest quality because these children are so small, their ribs are so close together that it's actually very difficult to get good enough resolution on those. It's no, we don't recommend isotopes at all, and that's in the new guidance. What is the perfect answer in 2B if it's a case? Well, the first thing is to have considered it. The first thing is to think, you know, I'm concerned about physical abuse, and I would want to know, I would want to understand the history of this, what the history was. And until I could be sure, I would move the child to a place of safety. That's the most important thing. So the age limit, thank you, Phineas. Oh, sorry, I'm missing one out, Samaya. Uh, Apart from communicating to the pediatrician, well, the pediatrician will then take the child into a place of safety. You'll arrange to do the follow-up imaging, and then that may be enough. That may be all you need to do. Um, but you need to look at the bones and all of that sort of thing, and then you may well find yourself being asked how the injury occurred and whether the history is compatible with the injury. And that can be really difficult because people come up with all sorts of things. But the rule of thumb really is that any injury in a non-mobile baby is they very rarely get fractures. Sometimes they can get fractures from, if you fall down the stairs while carrying an infant, for instance. That can give a baby a fracture. But, the ordinary rough and tumble of family life, there have been plenty of studies which show that it's really quite common, which this made me feel better because I was a very lax mother, I've got to say. But baby, it's quite common for babies to be tumbling around and fall over things, to be dropped off, changing tables, toddlers fall on them, dog walks on them, that sort of thing. And actually, they very rarely get injuries. So I think I'm behind. Dr. Khan, can you help me? Which one do you want me to answer?
Right. Just 1 second, please. Protocol. Can you tell them the, skeletal survey? I think this is what they want to ask.
So the protocol, I mean, it's quite long. There are about 23 different images, but I would suggest that you go onto the Royal College website. It's free for anybody. Download that, and it's got a list of the images that you need, and also a list of the follow-up and when you do it and that sort of thing. And also the head protocol. It's got all of those on there.
Another question is that should we ask for brain imaging if we suspect NAI?
So at the moment, the guidance is that brain imaging occurs in all children under 1 and that it's part of the skeletal survey. Over 1, not so much, because they normally have symptoms. And we do know that babies often that they can have no symptoms and no signs and still have a sign of a head injury. We know that in the under 6 months. Um, and but the place we haven't got a lot of evidence is 6 months to 1 year, and we're getting that evidence now. Professor Ophir, who also works at the RCR, is doing a European study about that, and they're updating that guidance. But at the moment, the guidance is CT head in everybody under 1.
Another question is that if we are suspecting SPA and initial survey is totally normal, should we send the baby home and recall after 10 days?
These are very good questions. The baby needs to be protected in that time because you don't know that there are no fractures there. So what we would quite often do is we often send them home maybe to stay with the mother. So somebody supervises the mother with that maybe the grandmother supervises the mother or something like that at the time, if it's completely normal. But no, the child, it's not normal until the second survey has happened.
Next question is, what is the age limit for skeletal survey?
So we normally do it up to 2 years of age. Um, but sometimes we would do it in older children. The main reason is that over two, a child can usually tell you if something's hurting. It's obvious and it's much more obvious on clinical examination. But the cases where there is an exception are either where an associated child, another child in the family has had really severe injuries. So just occasionally, it doesn't happen very often, but you find that there's somebody really, really violent in the family and that the children are really having a terrible time. And so you sometimes do a skeletal survey on an older child in that situation who's not the index child, if you sort of mean, a sibling. The other time when you might do it is the child is when the child is non-verbal, if they've got special educational needs or, complex needs, if they're immobile or non-verbal. And we do know that children with special needs are abused more often than others.
Any role of ultrasound?
Well, that's an interesting question. So ultrasound is not really useful for abdominal injury in children. It's really easy to underestimate injuries. I mean, you can sometimes see free fluid, but it's really not good. CT is much better. Some people use it for metaphyseal fractures, and I think that it is quite good for that. Um, the thing is that not many people have got the expertise. I think if you're going to do that, you need to make a real thing of it for yourself, and you really need to ultrasound the normal metaphysis and really get used to the normal appearances. But it could be quite a good tool. But usually, the radiologist is not around all the time, the radiologist with the expertise, so it's not really caught on, but it's a possibility. One thing I should mention actually is this is all in the guidance as well, but um, is siblings. So if one sibling is abused, it's very likely that the other one will be. And this is particularly true of twins. So if you find one twin with fractures, you should also image the other twin.
So, twins, and this is a question from my side. So, any other siblings also? But it all depends on the age, isn't it?
It
That will
does. So
be.
it's under two. But you're
Uh,
right. This can be a really complicated question because sometimes these families are very complicated, actually. And so there may be twins in the family, but then there may be an 18-month-old of one of the parents from another relationship who comes to visit the family at weekends or something like that. And sometimes it can be really complicated. And so there is a bit of judgment involved into whether you think those children are at risk. But certainly multiple births, definitely high risk, and they should always be done.
Right. Next question is that should this be always assessed by as should we say, a second opinion by a consultant pediatric radiologist?
Well, it depends on your level of expertise. There are quite a lot of people around the country who do have expertise in this area, and they're not pediatric radiologists, some MSK radiologists. The standard is that two people review it. And two people with expertise. And so, in many places in the UK, we form networks. So, it may be that there's one pediatric radiologist in a hospital, but so in the Southwest, for instance, they have a network. So, they'll transfer the images to each other. And another pediatric radiologist from another hospital will do it. So it is good to get somebody who's used to looking at these things, and we always double report them.
Right. So there were a few questions about MR. Basically, if you can highlight, you use it as a problem-solving tool, if I'm not wrong.
We do for we do for the skeleton, for the body. For the head, they would use MR for sort of longer term issues. So the CT is better for sort of acute blood and things, but sometimes you can suspect that there is a sort of longer term abuse, or there is some, say there's an altered conscious level and the CT is normal, or say they're fitting or something like that. So you'd use it more often in the head, and there's more in the guidance about that. That's not my area of expertise. But really, for the body, we'd use it as a problem-solving tool. I mean, there may be more of a role for that in the future, but doing an MR on a baby, a whole body MR, it's an acquired skill. It's a difficult, you need to give them a GA very frequently. It's quite hard. Sometimes we do just get some images when they're having their head done.
So I think that is about all. Just let me see if there is anything else.
Well, you're a great audience, so engaged. It's wonderful. Thank you.
Just one second. Yeah. So I think that is all. So thank you very much, Kath. But before you go, let me show you something. It was quite a historic session for us. And when the 187th person joined us, we hit this today.
How wonderful. That's wonderful. Well, it's a historic occasion for me too, because this is my last night really as president of the Royal College of Radiologists.
Wow, wow,
And,
wow, wow,
and
wow.
I would like to say thank you to all of those who are members or fellows of the Royal College of Radiologists. I've absolutely had a wonderful time, and I admire you all, and I'm so thrilled to see so many radiologists with such a thirst for learning and knowledge, to look after all our populations for the future. It's wonderful. The combination of this teaching, this thirst for knowledge, it's a wonderful job you do, Dr. Khan. Thank you.
Thank you very much. And thank you very much to all of the team who you can see on this slide, which were involved from June 2020. So
Amazing.
this has been uh, all of this is because of the people who contributed. So thank you to all of them.
Amazing. Amazing. What an effort.
Yeah. So, Kath, once again, it was a huge pleasure, huge privilege, and you just also mentioned that this is your last day or night as RCR
Yeah.
president. It was very historic for us. We are so privileged that you gave this excellent talk also, and I'm sure people learned a lot. So, thank you very much.
Thank you. And for me too, a pleasure to spend it with you. Good night.
Thank you. Okay, then, good night.
Thank you.
This. And then we'll do a session that's going to be tailored for pediatrics for your exam in FRCR. Okay. So I'm going to show you three cases, and one candidate, I will give the case each to everybody, to each candidate, and then we do the viva. Okay. As per the
Just one,
neuroimaging.
excuse me. I've actually totally forgot to make the candidates co-host. Just give me a moment.
Okay, okay, so no much, no issue, sir.
Candidate one, are you with us?
Good evening, sir. Yes, I'm here.
Okay, over to you, Mavish. Thank you very
Okay,
much.
okay, okay. So I'm going to explain to you first about the neuroimaging. Okay, so under 1 year, everybody has a CT head. But if we find a positive finding on the CT, we will proceed to an MRI, brain and spine. Anytime you find a positive finding in the head, bleed, or a fracture, you would go straight to an MRI for the whole spine as well. I've not shared the screen yet. The screen is not shared. There's there's nothing on the screen yet.
Okay.
Sir, I need you to let me share the request, the screen, please.
Yeah, now you can.
Thank you, sir. So, I'm going to go to our presentation mode. Okay, candidate one. This is a 23. So I want you to think of yourself, anybody who's presented with the suspected physical abuse, as a Sherlock Holmes, okay? And the pediatric team is going to be your Dr. Watson as well. So this is a patient. It was a 23-day-old infant who was brought to the emergency department. The child was brought with stuffy, congested nose, initially assessed by the nurse practitioner. And the mother then expressed that she could feel a bony lump on the left side of the baby's chest. And she said that, I think it might be cancer. So That's her X-ray first. Would you like to view it? Tell me something about it.
Okay, this is chest X-ray frontal projection of a child, pediatric, in which there are barely visible humeral epiphyses, but they have started to develop. I can appreciate that there is a healing left clavicular fracture, and there is a callus formation, so suggesting that it can be somewhere between 7 to 12 days of age. So as I've appreciated that it is not an immediately after birth film and there's a healing callus, so I will try to look for any other associated injury as well. And in my routine practice, I would like to zoom it. I suspect something abnormal in the proximal right humerus, but that can be projectional. And I'm also simultaneously looking at the contralateral metaphysis, which I'm not able to find anything. The scapular, so as I have a clear-cut one fracture and one I have a suspicion. So I would like to look in the ribs area, as this age is more characteristic for rib fractures. And I would like to trace them on the left side.
So I'll tell you, it's clear. We just have a clavicular fracture. Anything you would like to, so you're writing a report, what would you do next? You've written there's a clavicular fracture, you've told me approximately the age. What are you going to do next?
I would like to know the history, if the child has a difficult birth history or shoulder dystocia.
The child does not have any difficult birth history.
So I would like to assess the GCS if the child is eating and is playful, is healthy, otherwise looking. If there is deranged GCS, I would like to hold the child in the department and will arrange for a, or if there is any other symptoms like failure to pass urine or any abdominal bruise, then I will proceed with further imaging.
So the child reattended the emergency department. The mother now reported that while holding the baby in her arms, a bottle fell on the infant's child. And mother was now concerned that the child had some lumps along the left side of the head. Okay. So I'm not going to show you the CT head, but this is the normal. There's no bleed inside. I'm going to show you a 3D reformat. So.
Okay. So this is the 3D reconstruction of the same child posteriorly, in which there is a sutural diastasis. In my, there is no evidence, there is evidence of right vertex fracture line, which is not displaced, not comminuted, and there is a single fracture line. It is not a complex one, but I can appreciate some irregularities anteriorly. So I would like to see the anterior view as well. And the contralateral side.
Yeah. So there's just one fracture that you've pointed out. So now you have two findings. What's your thought now?
So I would like to see the CT head for further imaging, and definitely it is suggestive of an abuse, because if child fell normally, this is they don't fell in a axial loading way, and this is not and the vertex is a very strong bone, and it even in adults it requires quite a significant amount of pressure to be broken. And in the child, if it is a break, then definitely there has been a significant.
I think we will ask for. So now that we have two things, we're going to ask for a skeletal survey. Okay, so now we did the skeletal survey, the full skeletal survey. So we can now see that there's a clavicular fracture that's healing. Okay, so because there are 25 of these X-rays, to make them short form, I'll tell you we did not find anything else in the body elsewhere. Okay, so we just had a clavicular fracture, and we had a fracture in the skull. So now, based on what I've just told you a while back, what are you going to do next?
So I would like to see the CT and MR, would notify the pediatrician and the authorities. This child should be.
At the first point also, MRI. We're going to do next, go to the MRI. Okay. So we did an MRI and we did not find anything. Okay. This is not your exam. I'm just giving you live scenarios, how you would come across in your, they can possibly show you a screenshot and they'll ask you how you would proceed as well, okay? Since the last couple of years, because of the shortage of pediatric radiologists, lots of general radiologists are reporting in the UK, and there has been an increase in the number of pediatrics that is now shown in the FRCR. And safeguarding and SPA remains the major one thing that is tested in your FRCR exam. Okay, so now I'll give you a birth history. So the patient, the mother had gestational cholestasis. The infant was vaginally delivered at 37 weeks. There is no history of birth trauma. So now then the safeguarding team and the social services delved into her social history. Both parents are unemployed. The mother was a chain smoker. Mother has a known history of bipolar. Okay, and I'll tell you how we manage the case. So we have a peer review meeting. So the first thing you have to do is you've identified a clavicle fracture, and a fracture, that sort of flocculent clavicular callus formation generally occurs at 11 to 14 days. Okay, so there's a bit of there are different views, but generally now they generally recommend imaging the child from 11 to 14 days. That's the limit we do. Okay, so we had a flocculent fracture. So if the child was born 23 days before, the age did not fit with it. So although clavicular fracture is still a very well-known cause of birth history trauma, we agreed that the skull fracture was unusual and out of context. Okay, and this case was then referred to the ongoing social care investigation. Okay, now as a radiologist, you can be asked the clavicular fracture, what are you going to do next? So you would first say, and this is going to be for all your safeguarding things, that you're urgently going to alert the safeguarding team and alert them that you suspect this could be non-accidental injury. Okay, the wordings have to be very clear and concise. You cannot on the first say that you can recommend that this looks like a non-accidental trauma, or I cannot explain. In this case, we could not explain the cause of the fracture because there's no history of birth trauma, and then we could not explain that how could there be two existing fractures without any history of trauma. Okay, which is why this case was flagged up. So okay, so this for this example, so now once you've had a CT, we had a fracture, we will generally, because initially the CT brain might leave, you might have tiny subdurals, you might have some other findings, or you might have ischemia that can be missed on a CT. So we always will go for an MRI brain and an MRI spine. The reason we go for an MRI spine is because generally in kids with shaking and NAI, you have subdural hemorrhages. That's known as the reverse Mercedes Honda sign. You can look it up as well. Okay. So now we're going to start your viva. Is everything clear now? Do you understand the steps, or do you want to do anything else about it?
Yes, ma'am. It's okay.
Okay. I hope you understand the steps. It's a bit. You just have to go through the steps again and again. It's generally not that hard, but the first thing is you will always alert the safeguarding team. Whenever you see a fracture, they show you subdural hemorrhage, you're going to say, I'm going to raise suspicion, I'm going to alert the safeguarding team. These are going to be your, so flagging also has points. I think Dr. Imran, I did join in last week, he told you flagging or important urgent cases does have points in the RCR now. So always flag cases where you are concerned that. So this is a 13-year-old who, can you see my screen now?
Not yet.
Yeah. No?
Yes, ma'am, I can.
Okay. So this is a 13-year-old girl who presented to our department, and she presented with fever. She was breathless, she had fever, and she was generally unwell. And the history, what we were given, that this patient had traveled outside the country, South America, a couple of weeks back. Okay, and this is a 13-year-old guy. Okay.
Okay, so this is just X-ray frontal projection of a 13 years old girl, in which I can appreciate that there is a well-defined opacity with well-defined opacity is seen projecting over the left lower hemithorax. I can see clearly that a hard shadow is clearly visualized through it. It does contain through the opacity, I can see the lung markings. I can, however, not appreciate the continuity of diaphragm on the lateral side. There is a pleural effusion because I can see a meniscus towards the left side the background lung parenchyma is showing some prominent interstitial haze, and the gastric shadow is within normal limit. There is no hilar enlargement, no significant hilar enlargement. Trachea is slightly deviated towards the right side, which might be due to position or could be due to some lymphadenopathy. So if as the girl has presented, I'm also trying to look for underlying ribs. In my routine practice, I would like to change window a little bit to be more clear about the ribs, but apparently they don't look involved and they don't look eroded. So my differential is that it could be a case of any abscess uh, with a fluid in the fissure and with pleural effusion, which has led to cellating of the left diaphragmatic contour. I also suspect that there is some subdiaphragmatic collection as well, because, or it can be a posterior mediastinal opacity. So I would like to recommend a CT chest with contrast to see the underlying status. I would also like to know which country the girl has traveled to, because it will also help me narrow. Sorry?
She went to Brazil.
Brazil. So there is,
yeah.
okay. So some atypical parasitic infection, virals, and these kind of infections are more endemic in this area. I don't know now, but like in the Middle East, there is more of chance of a hydrated. I don't think of hydrated in this area. So it can be any atypical viral or viral infection with which has led to abscess. So I will do a CT chest with contrast urgently.
That's fine. Can you see my screen? It's loading. So I'm
Yeah.
going to scroll it for you just to make everybody's life easier, because we're really not able to. So I'm going to scroll it slowly for you, okay?
Okay. Okay, so these are the CT chest contrast enhanced images of the same patient, in which I would like to take a moment to scroll through the images, and then I will like to start commenting. I can appreciate that there is a well-defined density with air fluid levels seen adjacent in the left lower lung zone. Lesion has an air fluid level. It is leading to adjacent atelectasis. There is a thick membranous effusion adjacent to it. I can appreciate clear margins with the aorta and esophagus. There is, at some points, I have a suspicion that it is extending through the chest wall towards the beyond the rib cage externally. Multiple air fluid levels. This needs to be urgent drained. I'm also like to look at its communication with the bronchial tree. I suspect that. Sorry.
Which sequence do you want?
Ma'am, I would like to see the mediast coronal, and there is some lymphadenopathy as well. So the my provisional diagnosis is that it is an abscess with adjacent atelectasis, multiple lymphadenopathy in the precarinal, prevertebral region. There is a loculated effusion, which is at parts extending through the chest wall externally. There is evidence of adjacent partial lung collapse. And there is, yes, it is definitely compressing the left lower lobe bronchus. It needs to be urgently drained. Patient needs to be, there are some internal hyperdensity as well. So, ma'am, can I see the lung window as well? In the lung window, I am trying to look for any associated findings like a tuber, like there is train bud opacities which are seen bilaterally, more on the right side. I would like to take a history if any of the patient's relative has a positive tuberculosis history, or if the patient has previously herself been treated for TB. If this has been the case, then this is likely a tuberculosis abscess. Other possibilities include histoplasmosis or any atypical viral infections. abscess need to be drained, and the fluid or cytology should be processed, and after the culture and sensitivity, until unless the culture and sensitivity is done, patient should be isolated, because this can turn out to be a tuberculosis.
This is an 11-year-old child who's presented to us with pain in her left arm. She's just immigrated to the country. So she's a newly arrived migrant, and she's presented with pain. She did complain that she had fever a couple of weeks ago, but there's nothing active that's going on at this time. So her markers are fine.
Okay, so this is the X-ray left humerus frontal projection of a pediatric age group patient, in which I would, ma'am, can you please zoom a little bit?
Yes, of course.
A little bit. Zoom. Yeah. Okay. So I can appreciate that there is a well-defined medullary lesion seen with a ground glass matrix, internal lucencies, adjacent areas of endosteal scalloping, part of lesion showing bony scalloping. It has a very narrow, it is longitudinally oriented in relation to the long axis of the bone, and there is a narrow zone of transition. There is an adjacent subtle periosteal reaction evident on the lateral side. I cannot appreciate any significant soft tissue thickening adjacent to it. There is no evidence of internal calcification. Ma'am, can you please zoom out? In my routine practice, I would also like to see, so I would like to comment on the adjacent joints, which are normal. There is no evidence of any other similar looking lesions in the rest of the visualized bone, including radius ulna and scapulae and the ribs. So I would like to see any other view if available. Okay, so in this view, I can appreciate that there is a periosteal reaction seen along the medial cortex. The periosteal reaction visible along in the previous X-ray, which was seen subtle on the lateral view, is somewhat evident here. There is a bone break, and I can think that there is an adjacent soft tissue, not soft tissue thickening. There is some buckling of the fat planes seen adjacent to it. So I would like to arrange, if not already done, CBC and ESR C-reactive protein, the amount of the eosinophils, neutrophils, to see any underlying infection, chronic infection going on. It appears that the bone break can be due to any existing lesion with a pathological fracture with periosteal reaction. Other possibilities include a chronic osteomyelitis. Another possibility in this age can be eosinophilic granuloma. I would also like to say if the patient has any other pain or skeletal type of symptoms in any other part of the body, or as the child was migrant, so I don't think there will be a record available. So I will proceed like this.
She doesn't have anything. I've told you.
Yeah, it can
So
be
what would you do next?
Ma'am, I will do MRI with contrast after these investigations which I have requested.
So I'm going to show you the MRI. Yeah. That's the patient's MRI. So one thing you all need to remember that children move. A lot of the images we get are highly degraded by motion artifact unless we give the child GA. And because GA is not beneficial to kids in long terms, it can cause neurodegenerative disorders. We try to avoid it. So most of the times you would get images that are degraded. I want to try the best what I can for you.
Okay, so these are the star images coronal of the same patient, in which I can appreciate that the medullary cavity is showing a diffusely hyperintense signal. As evident on the X-ray, there is a bone break through which the internal hyperintense signals are continuing with the soft tissues. There is a diffuse type of hyperintensity, which is seen in the muscular planes along both medial, lateral, both sides. There is a dense periostitis, and there is undulating margin or endosteal scalloping. Region is quite extensive. It wasn't that much extensive appearing to me on the X-ray, but in this, it looks more bigger than that. So I would like to do a MRI with contrast, T1 FET set, to see the extent, to see any. I'm thinking of in osteomyelitis, but just to see the adjacent bone. These are the plain T1 weighted images in which there is a bone break and through which there is a cloaca, and it is continuing outward. It looks like a chronic osteomyelitis. I would also try to look for a hypointense lesion within the medullary cavity to suggest a sequestrum, because that would be necessary to be mentioned to the surgeons. It's need to be taken out. There is a diffuse hyperintensity in the adjacent bone. Ma'am, can I see that even contrast enhanced?
We don't have contrast enhanced, unfortunately.
Okay, so
what's
yes,
your
there is a
diagnosis?
diffuse chronic osteomyelitis of the left humerus with adjacent cellulitis.
So this is another child. I think the child was around, not sure about the age, 4-5 years of age, but she's presented to us with an increase in her abdominal girth. So we went. So she had an abdominal girth. So I'm going to show you the images that matter. Just waiting for the case to download, and I'm going to show you, scroll it for you.
Okay, ma'am, should I start?
No, I'm going to scroll it. You can be relaxed. Okay. Let me scroll it all for you, and then you can. It's still downloading. That's why I'm just waiting for it. It's a whole body.
Okay.
Yeah, so it's just still downloading. Let me see if I have some more images that I have. So this one I have contrast. Yeah, I think the CTs just take a long time to load. So this is a child who's presented with increase in the abdominal girth. That's her.
These are the CT axial non-contrast enhanced images of a child from head till the, I believe, pelvis. I can appreciate that there is a diffuse hyperdensity seen within the midline in the abdomen. It looks like it is hyperdense relative to the adjacent structures, and there are specks of coarse calcification seen within it. There is an adjacent ascites. Region seems to be centered, epicenter is in the midline, in the retroperitoneum and in the abdominal region as well. It is displacing the bowel loops anteriorly. There is a dilated left pelvic ileal system, might be due to the pressure effect on the ureters. There is ascites, there was bilateral pleural effusion. In the CT brain images, there is a diffuse periostitis along the both iliac blades, and also I suspected a similar kind of periostitis along the both mandible condyles and in the sutural region.
What do you want to see next?
Ma'am, I want to see the bone window. So there are multiple deposits seen along the both mandible on the both side of both medial and lateral cortices. There was also a hyperdense soft tissue density mass lesion. Multiple vertebrae also show some speculated type of periosteal reaction. The same reaction was also seen along both both iliac blades. I have also doubt of mediastinal lymphadenopathy. Yes, I think I've commented on the bones. Yes, there was one more thing. There was bilateral sutural masses as well along the both anteriorly. If you go a little bit, yeah, here, and there is a posterior midline hyperdense soft tissue density mass. The ethmoids and the maxillary sinuses appear to be hyperdense. There is a soft tissue density projecting in the pharyngeal region as well, which could be due to a large adenoid, or it could be part of the mass. Ma'am, can I see the post-contrast images? I want to delineate the exact extent of the lesion. The sutural areas show hyperdensity. It can be malignant deposits of the same lesion.
What do you think the lesion is? What's your thought process?
I think the lesion is in this, it is most likely neuroblastoma, because there are many features which support it is that it is a midline, it is in pediatric age group, and moreover, it has a bony diffuse metastasis. Other likely differential could be lymphoma, but lymphoma don't have such chunky kind of calcification, and lesion seems to be encasing the aorta and IVC. I would also like to see. Sorry?
What are you going to do next?
Ma'am, I would like to advise. I would like to advise a nuclear scan, MIBG scan, to see the metastasis. Patient needs to be urgently communicated because there is the bilateral effusion. There should be a percutaneous nephrostomy. There should be ascitic fluid drainage, and the airway and the foodway should need to be secured, as they are significantly narrowed at places. And after that, the patient should be referred to MDT for tissue histopathology. And next should be the step should be a scan, nuclear scan, MIBG.
So this is a child who presented to us with nasal stuffiness, and we did a CT sinus on this for this child.
So these are the axial CT images, bone window of a patient who presented with the stuffy nose. I can appreciate that there is a soft tissue density mass lesion seen arising from the nasal cavity, filling the middle turbinate and extending into the left maxillary sinus, as well as obliterating the posterior nasopharyngeal region partly. I would like to see it on the coronal, the bone window coronal.
So I don't think we have coronal in this. Unfortunately, I don't have a coronal. So if you don't have a coronal, what do you think this is?
Ma'am, this can be a sinonasal polyposis, it can be an inverted papilloma, enterocoinal polyp, or a fungal polyp with a superadded fungal infection. There is a posterior periosteal reaction as well. The pterygopalatine fossa bilateral is normal. The pterygoid plates are normal. I would like to see the soft tissue window.
You want to see the soft tissue?
Yeah. Yes. So this is the soft tissue window of the same patient. Again, there is demonstration of the same finding. There is ethmoid sinusitis, and there is a soft tissue density mass which is leading to widening of the choana.
Yeah.
And it is it can be going from maxillary sinus to the nasal sinus, or from or the other way around.
What are you doing?
Also, ma'am, I would like to do an MRI with contrast.
What is an MRI going to provide you more information? How is the MRI going to provide more information?
It is so there is a on the T2 weighted images, if there is a tigroid type of pattern, it is more suggestive of inverted papilloma.
Yeah.
And moreover, I would also like to see the signals to see any superadded fungal infection. If it is altered signal on the T2, that would be suggestive of a superadded fungal infection, and that can be invasive. So on this particular CT, also I forgot to mention there wasn't any bone break or any lytic or destructive lesion of the bone.
Okay. So this patient presented to a child presented to the ED, presented in the afternoon in the pediatric emergency, and it said this child had a 10-day history of torticollis, and the child also had drooling from the mouth and torticollis, right? And this is the CT. Okay.
Okay. So this is the plain CT axial section, brain window of a child, in which I can appreciate that there is a well-defined hypodense cellular supracellular lesion. Part of it is calcified. It is projecting superiorly into it is extending posteriorly into the prepontine region, leading to its effacement. It is also extending superiorly into the floor of the third cranial fossa. I would like to see it in the coronal window to delineate its anatomy further. There is no evidence of any hydrocephalus on this particular image, and I didn't appreciate any other similar looking mass in the posteriorly. So there is so this is the mass which is hypodense. It is calcified. Ma'am, can you please stop at the region of the pituitary? So I would like to comment on its relation.
Yeah.
With so it is supracellular. and it is bulging into the floor of the third ventricle again, as I said, and it is calcified. I'm thinking of adamantinomatous type of craniopharyngioma, as it is more common in the pediatric age group. In my routine practice, I would advise MRI with contrast to see the adjacent encasement or abutment of the internal carotid vessel. Also to see any metastasis or any other synchronous lesion.
So this was a child. No, I think this cannot be displayed. Some patient issue. So let's go back onto your viva. And let's start with the first case, okay? So you've answered all the questions, okay? And you're very good viva, but there are a few things that I want to raise with you. And I'll explain to you why. The first thing is when you were discussing it on the X-ray, you told me the diagnosis, right? You said hydrated cyst. And I showed you this, and that's why I showed you. Can you see these are the daughter cells? Is it not like the water lily sign, the Serpingia structures? So this is basically a cavity that's filled with a lot of daughter cells, right? And that's compressive pleural atelectasis, and there's the pleural effusion, right? You have to be able to identify between an abscess and a hydrated cyst, right? Because the management is poles apart. You cannot tell the pediatrician that go and drain, you know, in the hydrated, you do not drain. You give them antihelminthics and you refer them and they get pair, right? Puncture and aspiration, right? You can never ever drain it. That's going to reach in an anaphylactic reaction in the patient, okay? So please be very careful when doing this and suggesting and deciding what this is, okay? And you gave, and when I was showing you the X-ray, you said to me hydrated cyst, right? And that's why I stopped it here and I explained to you. If you look at the image here as well.
I thought I ruled out because of Brazil.
Brazil. I want to explain to you. Brazil also can also have these things, right? So don't rule it out on the place as well. Okay, so you can see them. You can see the daughter cells. They're very quite apparent. This lamellar structure. It's something that's very pathognomonic, or it's like an ant mini. So this structure, and you have to be just very careful when you say that. Okay, this is go and drain it. Okay, because we can cause an anaphylactic reaction in the patient, right? So, what's the next patient that we did? So this patient, you said the right things and you told me everything right as well about the osteomyelitis, right? So I want to tell you one thing, and that's something that's happened to me in real life as well. Most of the times, clinician colleagues will not give us the right picture, right? It's happened to me, which is why I'm very suspicious when my clinician tells me that the inflammatory markers are not raised. So this patient, and I did give you a bit of a hint. I said the patient had fever before, now there's no fever. So what the clinicians generally do, to give these patients, the child had fever a couple of weeks ago. So the child, they give the patient a dose of antibiotics, right? So the inflammatory markers are normal, but this is acute on chronic osteomyelitis. So you picked up, this is acute on chronic. You told me the involucrum, cloaca, sequestrum, everything. Can you see there's enlarged lymph nodes as well, right? And so this, but with this, this is not cellulitis. Okay, it doesn't make sense, does it? So this is, it could be myositis. Okay, so myositis and cellulitis are a bit different, but this is acute on chronic osteomyelitis. Okay, so, and do you see the lymph nodes, right? See,
yes,
those are the enlarged lymph nodes, right? Yeah, yes. Another thing is that, you know, we don't like to do that much contrast imaging. So like if we have seen on STIR, it's like quite apparent to me what I've seen. I've seen everything, right? That's the, you see, everything is here. You can see, I'll show you the cloaca is also visible. That's the cloaca, right? You see sequestrum, everything, right? So you picked it up, right? And you did it, okay? Acute on chronic. So you generally refer to them. A safe way to is, it's acute or chronic, you raise the suspicion, but always remember there are some sarcomas also that mimic this sort of appearance. So always say that I would also refer it to the sarcoma center in case you're suspicious. Okay, nobody's going to take your marks away, but they would give you, you have to be safe at all times. Okay, but you said chronic or osteomyelitis, so you did pick it up. Okay, it's not that you've not picked it up. And one more thing I want to explain to you, that I kept showing you a couple of things for somebody. I kept pointing a couple of things. The RCR examiners are very nice generally. Okay, they will guide you. So listen to their prompts, listen to the history. I said the patient had some, can you see this is the periosteal erection, the thickened cortex? Somebody is asking for the findings. I'm just explaining again. That's the cloaca. Yeah. And then there's a small bone, there's an hypodensity inside. So that's the involved. Okay. But I think it's very pathognomonic, acute and chronic osteomyelitis. So there's nothing to it. You picked up the craniopharyngioma. Very good. That was excellent. You picked it up. You described to me, right? Chronic osteomyelitis. Okay, that was an enteroconal polyp. Okay, you said the right things and you do it, but I want you to not prolong your viva. Okay, don't prolong your viva. Just make it short and crisp. You just have to tell them the basic findings. You would just tell them that this is the enteroconal polyp. You don't need an MRI generally for this. Okay, and you would refer them to the ENT. You could see the osteomeatal complex, the widening, right, and bony remodeling, right, and you would just refer to them the ENT, right. Similarly, in the that was a neuroblastoma, okay? And you said the right things again. I'm just telling you, this is a smart way of giving the viva. You just make your answers short and crisp. You gave the description, you described it beautifully, you said the calcifications, you said the right words. I just want you to be a bit more saying short and crisp, and just say like, I suspect this is a neuroblastoma and I would refer to the NMIBG. You're not going to ask, we're not the clinicians, okay? We are clinical radiologists. We would ask for MIBG scan, and I suspect this is, I'm going to refer this to the pediatric MDT or the tertiary care level center and ask for the new MIBG scan and everything, okay? So because the patient needs a reference, sometimes you're not working in a tertiary care, right? And you just tell them the findings and you refer it. So we're not going to tell them that this is pleural effusion. You would describe the findings, you'd ask them. And there's another thing you said to me regarding the SPA, suspected physical abuse case, okay? We don't go around asking what are the GCS, what's this. We generally, I do have a discussion with the safeguarding team, but these are things that they generally discuss and do. And somebody had asked the question, the neuroblastoma case. Yes. So the neuroblastoma case also, I want to explain to you a couple of things. The imaging might be limited at times in the neuroblastoma. This was a whole body because it wasn't done in the UK. So we are, so I'm going to show you the findings again. And you picked up the findings beautifully, okay? I'm very impressed the way you picked up the findings in the neuroblastoma. They were very subtle findings, but you picked them up very beautifully. You described the right things. I just want you to be very short and crisp, okay? Save yourself, save the people. People like short and crisp things. Even the reports are very small, generally very precise and to the point here, right? So let's go to this thing. So you picked up this. These were metastasis. The mandible, you picked them, they were soft tissue deposits. And can you see the globe also, right? These are the extraosseous and dural mets that are developing, right? And you picked them up, and I was very impressed. And you picked up the fusion and you described the right ones. And this is the entire neuroblastoma. So with calcifications, it's encasing the aorta. And then the major finding that is pathognomonic was in the bone. Sorry for this delay. It's like just take a lot of time downloading. Yeah, do you have any questions while this is downloading regarding the viva? Do you want to ask me anything? You've said the right words, just be very careful. Suspecting management, okay? That was a bit of a close call when you told me that I'll ask the surgeons to drain it. Please don't do that. Just be a bit more wary of it and see the hydrated cyst, okay?
So ma'am, I have one question that clavicle fracture if I raise the call and the authorities will withdraw the child from the parents.
So I'll explain to you what happens. So I'll tell you what happens. Okay. So yeah, yes, I was listening to it. Okay. It's a very difficult call as a pediatric radiologist. It's a very difficult call. It's very difficult for the pediatrics as well. But at the same time, so there are a lot of factors that are involved in the safeguarding. We generally convey the findings to the pediatricians. I have a discussion with the safeguarding team. A couple of times the safeguarding lead comes and says, we discuss. We might not agree with each other. Sometimes we send it for second opinion. We send it for third opinion. In the same case, the one I showed you, the skull fracture, I reported a skull fracture. My second colleague was not confident, and he said that maybe there are accessory parietal sutures as well, right? Accessory bone. And he said, I'm not confident. And this went for a third reporting. And I said, no, it's a fracture, okay? The clavicle, the point is that we have to look at the safety of the child. It's a very difficult call. I'll say again, the child is removed from the parents. You're responsible for that as well. But you have to put, that's why I said, it's more like you're a Sherlock Holmes. You have to put all the things together. That is this clavicle fracture. The clavicle fracture child came in out of us. And this was during to the pediatric MDT. They just, in the last minute, one of the clinicians said, oh, we had a child who came with a clavicular fracture, birth trauma. And when they put it up, and I looked at the age and I said, but this child is 23 days, shouldn't have birth trauma, 23 should be healing. Again, there are exceptions. We did recall in the child. So in most cases, they might come in your daily practice. You would see a rib fracture like Kath Halliday showed, right? And that's when you raise these things, right? So you are always going to raise the alarm. There's always going to be help by you. Yes, the child is removed from the social services, by the social services. It's taken to a safe place until we are sure. But then it's a narrow line. What if we don't remove the child? Mm-hmm. And what if this potential harm is caused to the child, is done to the child? So there were cases in which we did not do it because we doubted, and the child ended up representing again with more serious injury next time. Okay, so we have to be careful, and we have to take in always say, I'll discuss with the safeguarding team, but you have to raise the alarm that I'm suspicious of the history given. Like even in this history, I mean, the history was very odd, wasn't it? Like there's a lump, there's a cancer growing, there's no history. We went back, so the safeguarding team went back to the gynecology department. They went to the people who did the delivery. They spoke to them. They looked at the notes and everything. So it's a very big process that's in place. Safeguarding is very difficult. It's a very hard call, and it's a very difficult call because of the reasons. But at the same time, UK is still the leading place in the whole world who has good protocols, safeguarding protocols in place, right? So we still have a very good system in the UK. I think it's better to be safe than sorry. I myself, for my personal opinion, we do these things, okay? And we do this. And somebody had asked earlier a question. Generally, it's recommended that a pediatric radiologist or somebody with a 6 months experience would report the scans. It's just because a lot of things are misreported if you're not familiar with them, okay? So thank you so much. Your viva was wonderful, but I would again say and ask you that just keep things a bit short and crisp. Other than that, you were fine. There's nothing to be.
Thank you so much, ma'am.
No problem.
Thank you for your
no problem. So, do we have a next candidate?
Yes, I am here.
Okay. So, as with before, we are going to do one. This is not an exam, so don't worry about it much. Okay, it's just a guidance, like just to go through what we have learned. Okay.
Okay.
So this patient, now, this is a little bit different. So this patient came to us. It's referred by a child protection team after a healthcare visitor visited the patient, visited the child, and they found that the child had a bruise on the buttock. And the mother said that the child was not present in R. And she said that I was doing some work in the kitchen or somewhere, and the child was lying on the buckle strap without a diaper at that point, and the nappy was not fastened.
Okay.
So what were we going to do next? We have a bruise. So once we have a bruise, the safeguarding team raises concern, and then we go for a skeletal survey. Okay. So that's the physical examination. It was purple, blanching, right buttock. We also had another one as well, and the left knee due to concerns of bruising. we started doing more radiological investigation. So these findings are all, I want to say, they come through the clinician. The clinician is the one who asks for skeletal survey unless we are doing something in our daily practice and it triggers us, right?
Okay.
This is her first X-ray. Okay, I'm going to show you a couple of X-rays, sorry. Okay, and because I'm just going to show you some key X-rays and just a couple of ones, because 25 X-rays would take a whole day, right, to watch them at least 1 hour. For me, people like me to view them. So I'm going to show you a couple of X-rays and I want you to look at them closely and then you tell me, okay, I'm going to show you these first X-rays. So I want you to look at this X-ray. Look at it. And then
Okay.
yeah. So this is one X-ray. Have you viewed it or you want to wait the time over?
Can I explain the findings or explain at the end after all X-rays?
Okay, this is the second X-ray.
Okay. Okay.
These are a couple ones, the final ones. Do you find, did anything catch your eye?
In the chest X-ray, I can see some healing fracture of the ribs with periosteal reactions, and these are bulbous in appearance at the level of the lateral margins. And in the long bones, I can see the metaphyseal corner fractures, bony erosions along the metaphysis of the distal tibia and the distal radius.
Okay. Okay, this is this. I'm
Yes.
just giving you. Since we're going to do this CT, right? So the CT head, we didn't see anything. To be fair, it was normal. So that's why I've just put up this image. It was normal.
Okay.
Normal. Didn't find anything. So now I'm going to show you the follow-up. Okay. This is after follow-up X-ray. Anything catch your eye?
There is an acute fracture on the left on the left side of the medial aspect of the rib with bulbous appearance along the lateral margins, which I show on the previous X-ray.
Sure. What's your thinking process going? What are you thinking right now?
In this age, after 2 months of the age with multiple injuries, as the child is not walking and has no history of trauma, I am concerning for the suspected physical abuse. As the child's safeguarding team already thinking about it.
We did a CT test as well. This is the CT test. I've just given you a snapshot. It proves that we can see, and you can see it right there, right?
Yes.
The new one we can see there. So that's very good the way you did. So that's the radiology report that we gave out, that there were fractures in the 4th and 5th ribs, florid calcification confirming healing fractures, and this confirms the fact that the right and rib fractures are two separate events. We have given a clear indication if dated according to the radiological appearances. And then we said there's a fracture in the 7th rib bridge to the bulging of the cortex. Okay. Whenever we suspect, I want to add to you as well, if we suspect a lot of times that we do radiology views of the radius or any long limb and we are not sure this is a fracture, so we generally ask them that in the follow-up imaging, please do more views, okay, additional views, just to make sure. So these were the clinical findings and the summary of the findings, okay. This is just a view. So this child was unfortunately in the end put up for adoption because the parents were found negligent because of the traumatic effects and due to the pattern of injuries.
Okay.
So this patient, very good, excellent. You found the rib fractures and you described them. So very good, very well handled. So now we're going to go to yours. This is a patient, a child who presented to the department in the A&E with concerns of not walking or no hip bearing, okay, no weight bearing.
Okay. This is the X-ray chest frontal projection of a skeletally immature patient.
Can you see X-ray of his chest?
Yes, I'm saying. X-ray pelvis, sorry.
I thought I put the wrong image. Sorry.
Okay. This is X-ray pelvis frontal projection. Can you slightly change the window? In which I can, yes, thank you. In which I can appreciate there is a flattening and reduced height of the left femoral epiphysis, and there is a cortical irregularity along the epiphysis and the superior metaphysis of the left femoral shaft. Acetabular space is widened, joint space is widened at this level. There is no dislocation medially, posteriorly, or superiorly, and rest of the bones are normal. Contralateral hip joint is normal. There is no evidence of fracture or dislocation in the rest of the bones. So findings are consistent with avascular necrosis of the left epiphysis, that is called the leg calf Perthes disease. I would refer this patient to the orthopedic team for the further management and recommend MRI for further evaluation.
So sorry, I've got so many tags. I just wanted to remove them. Yeah. So this patient presented to us in the in the ED, and she complained of pain in her right arm.
This is the X-ray right humerus frontal projection, in which I can appreciate well-defined lucent intramedullary lesion, which is causing expansion of the bone and subtle thinning of the cortex. And there is an associated cortical lifting and pathological fracture, which is passing through the distal end of this lesion. There is no, the lesion has narrow zone of transition. There is no associated periosteal reaction, calcifications, or any soft tissue component. No endosteal scalloping is appreciated. The lesion has subtle ground glass and lucent matrix. The rest of the bones are normal. I would like to see the lateral view for further confirmation of my findings. So it confirms it's a pathological fracture passing through the basal part of this bone, and sclerotic hyperdense focus fragment seen at its base. It's likely a fallen fragment sign. So it's a case of solitary bone cyst with pathological fracture. And very less likely possibility of the fibrous dysplasia. Because fallen fragment is usually pathognomic for the solitary bone cyst. I would urgently refer this patient to the orthopedic team for the curettage and cementing and filling and fixation of this fracture.
So the child who presented to us with the swelling in the forehead. and she had some fever as well, and she presented to the ED with fever.
Image is not loading properly.
Loaded on why? Is everybody else also seeing the same issue?
I can't see it in the middle part. It's located on the left-hand side and not looking clearly.
Actually, I could see it very well. It was fine for me.
Okay.
Can you see it
I
now?
think I should. Okay, now clear now. Clear now. This is a CT brain, non-contrast images, in which I can appreciate soft tissue attenuation material opacifying the right maxillary, ethmoid, and bilateral sphenoid sinuses, causing their expansion. And there is soft tissue component which is seen adjacent to the both frontal lobes, uh, with small abscess like cystic collection in the anterior aspect and associated soft tissue thickening. Rest of the brain parenchyma is normal, no intracranial hemorrhage, edema, mass effector, midline shift, no ventricular dilatation, no hemorrhage, or no any acute. I would like to see the bone window for the further evaluation and coronal view if available.
Your coronal view. What's the coronal?
Can you change the window, please, if possible, on the bone window?
I can show you the bone window. Do you want the coronal first, or do you want the bone window?
Coronal bone window, if
You
available.
want the coronal bone window.
On the coronal bone window, again, I am seeing the findings, opacification in the sinuses involving the maxillary, ethmoid, and frontal sinuses. And would you focus on the frontal sinuses?
Yeah. That's the frontal sinus.
Okay,
Fine.
okay, thank you. So, if post-contrast image is available,
This is post contrast. Sorry to tell you, but this is post contrast.
okay.
It's like this in children.
On the post-contrast images, there is a collection, peripherally enhancing collection on the front, adjacent to the bilateral frontal bones with associated soft tissue swelling. So, in conclusion, it's an infective and inflammatory disease process, maybe the extension of the sinus disease, which is causing these abscess formation in the scalp region with associated soft tissue thickening. As I can't see any epidural component, intracranial component of this collection, so it still can be the possibility of the Portman syndrome, but usually it causes the osteomyelitis of the bone and with associated epidural collection. I can't see any definite break in the frontal sinuses. So in conclusion, it's an inflammatory disease process which is involving the sinuses along with abscess formation in the frontal region.
Do you want
I
any
would
other
want
imaging?
MR if available.
So, can you tell me why would we need an MRI first?
I want to clearly see the any intracranial extension is present or not. The status of the brain, any edema or something else.
Hmm. So,
This is the T2 weighted MRI images of the axial images of the brain, in which I can't see any abnormality within the brain parenchyma, no edema or epidural collection. So, again, I can appreciate a cystic lesion in front of the frontal sinuses, on the frontal, adjacent to the frontal bones in the scalp. I want to see the post-contrast images, T1 weighted images.
Let's see, I don't have contrasting. I think it's a call. Let me. So, what's this? Oh, this is.
On the post-contrast images, no abnormal enhancement seen within the brain parenchyma, no meningeal thickening or no enhancing lesion appreciated within the brain. So in conclusion, it's all findings of CT and MRI. It's an infective process which is involving the sinuses and causing an abscess formation in the scalp.
So, this is a child who presented to us with respiratory distress.
Yeah. Any history of this patient?
So this is a twin. There were two twins, okay?
Okay.
And this child, twins are generally preterm. We kept doing X-ray. This child has respiratory distress, okay? And we have kept doing X-rays, and every time we did an X-ray, this is what we saw.
Okay. This is the X-ray chest frontal projection of skeletally immature patient. I can't see a humeral epiphysis, so likely it's a premature baby. There is a volume loss of the left lung, and there is complete opacification of the left hemithorax, indistinct borders of the heart and the diaphragm, and the mediastinum is completely shifted towards the left side. There is a hyperinflation of the contralateral lung, and which is crossing the retrosternal region. I can appreciate the nasogastric tube, which is seen in place normally located below the diaphragm. And another tubing is seen on the right side. So rest of the structures, no rib fractures or soft tissue abnormality seen, no pneumothorax or pneumomediastinum seen, visualized abdominal viscera are normal. So in conclusion, it's likely a lung hypoplasia with ipsilateral mediastinal shift and contralateral hyperinflation of the right lung. I would like to see the previous imaging if available.
It was the same. We did 2-3 X-rays. They always kept up coming like this. What would you do next?
I would like to see the CT chest.
Just downloading.
This is the CT chest, non-contrast mediastinal window. I'm looking at the images. There is complete shift of the mediastinal structures, including the heart, mediastinum and trachea towards the left side. and the visualized abdominal viscera are normal. I would like to see the lung window. On the lung window, there is complete collapse of the left lung and hyperinflation of the right lung. I would like to see the coronal window to see to assess the tracheobronchial tree if there is any mucus plug or anything.
Stop. Where's this one? 1 minute, let me stop my screen sharing. It's not. Yeah, can you see it now?
Yes. On the coronal window, can you please scroll it? Left bronchus is not visualized.
What are your thoughts?
There is can be endobronchial mucus plug, which is obstructing the bronchus and causing complete collapse of the left lung. And the other possibility is hypoplastic left lung with contralateral shift. If post-contrast images are available to rule out any mass, which is less likely in this age.
So this was a child. I have very selected images. Okay, I'm just going to show you a few selected images. Who presented to us with increasing abdominal girth, and they said she had lumps on her face. Okay. Can you see my imaging?
Yes, yes, I've seen.
It's getting stuck. Yeah. This is one image.
Okay. These are spot images.
I can. There are a couple of images they're not sharing. Let me restart sharing it. Sorry. It's stuck. Reopen the scan. Open too many cases. Yeah. These are a couple of spot images. Okay. I was just going to show you the lumps in the child's face.
In these multiple images, on post-contrast sagittal images, I can appreciate oblong-shaped extra-axial, multiple extra-axial masses, which are compressing the underlying brain parenchyma, and these have a soft tissue component also. These soft tissue ligands are also appreciated in the both orbits, which are causing compression over bilateral lateral rectus muscles. However, no definite infiltrations in these images. Optic nerve seems normal. Brain parenchyma seems normal. So, any other images available like T2?
What are you going to see on T2?
As I can see the signal characteristics basically. On FLAIR images, the associated any mass effect and edema in the brain parenchyma.
Any thoughts what
So,
this
so these extra-axial lesions with bony involvement and associated soft tissue component in young patient, this age group, it's likely a metastatic disease from the neuroblastoma. Neuroblastoma have a tendency to involve the bones, and the orbital lesions are consistent with these findings. So it's a neuroblastoma metastasis. I would like to see the further abdominal imaging to confirm my findings.
What
And
sort of abdominal imaging would you ask?
in which I can appreciate the suprarenal mass. I would like to see the further extensions of this mass, calcifications, and other things.
So I think
I
this
would
is
advise MIBG and bone scan this patient because 30% neuroblastoma metastasis can't show uptake on the MIBG. So advise both MIBG and bone scan for the further confirmation of my findings.
So this is the end of the viva. Very good, excellent. This is the
Thank
neuroblastoma metastasis. Okay, this is pathogonic.
thank
You see this. This is neuroblastoma. This is raccoon eyes. You see the proptosis, everything. That's what's causing. Okay, all these extra osseous, they are dural based. All these metastasis. This is pathogonic neuroblastoma, and we would advise for an ultrasound. Urgently refer it. Flag it up. Very well done. You answered all the questions and you shared everything. And I think the first case also very well done. That was an SPC, and you picked it up. And I was strangely, it was not picked up as an SSB in my trust. We did MRI first to confirm it. Generally, we would still do an MRI. Okay, so I was waiting for you. You didn't ask me for an MRI. That's why I didn't show it to you. You know this case, this child, premature one, and you said the right things. I just want to show you there's no bronchial tree. Okay, the bronchial tree was hypoplastic, which is why it's pulmonary hypoplasia. There's no mucus plugging. Okay, anything. I did an ultrasound as well on the child. Unfortunately, the ultrasounds are actually. Let me show you this CT with contrasts again, and you can see, and I think you picked it up as well. You can see there is no bronchial tree. Okay, the bronchial tree is hypoplastic.
Yes.
There is. Let's see this thing again. Okay, there is no. Let's look at this again. So you know that there is no bronchial tree right on the right. Okay, there's a complete cutoff. But it's right to raise a suspicion of mucus plugging. I won't disagree there. But this is pulmonary hypoplasia. Okay, this child who did go and was referred to the tertiary care center for the management. Okay, so very well done. You picked up the right things. And do you have any questions?
No, thank you so much. Thank you.
So, candidate number 3, I think. Yeah.
Yes, ma'am, I'm here.
Perfect. Candidate 3. So you're going to be extra special because I'm just going to show you images for your third part of the suspected physical abuse. And I will tell you the story, but I'm going to show you the scans and I'm going to scroll them for you. Okay? So
Yeah, that's okay.
Okay. So, right. Downloading announcement. I'm just waiting for it to download the case, okay?
Yes,
So
okay.
this child presented to in the ED. Okay, this came in the night shift. The registrar was on duty, and the history was that the mother said that she was co-sleeping with this child. It's my Zoom. She said she was co-sleeping with the child, and she said that she turned on her side, and the child fell from the bed onto the ground, which was carpeted. And now the child had a bogey swelling on the left and presented with some sort of seizures, and we did a CT.
All right.
So
So presented with CT scan axial sections of brain, unenhanced study. Okay, I can see that there is swelling in the extracranially on the left side, and also there is some subdural component noted. However, in my routine practice, I will like to zoom this image. I can also see a focus of hyperdensity in the adjacent brain parenchyma, which could suggest of the underlying parenchymal hemorrhagic focus.
is
Um,
this zoom enough?
yeah, that's zoom enough. And I will also like to see the bone window to look for any underlying fracture, and also the rest of the images to see for any countercoup injury. Okay, on the bone window.
Go ahead for you. It's downloading. So.
Okay, I can see that there is a fracture in the left parietal bone.
Mm-hmm.
And also there is a fracture in the left frontal bone.
Want to see anything else?
Um, yes, I want to see the brain window again. Otherwise, there are fractures, tooth fractures. So there's also subdural hemorrhage along the left parietal bone, and I will like to see the any previous images if available. And otherwise, these two fractures couldn't be from the fall from the carpet. So I would discuss the findings with the colleague pediatric radiologist, and also discuss with the pediatrician, and alert the social security team for discussion of any suspected physical abuse. And
Very
also
good.
will request a scheduled survey.
Yes, very good. So now I'll guide you through this thing. So you did the right things. Very good. Excellent. You'll get full marks for this because you've done it. Okay, there's only one thing I want to show you. This is very pathognomonic for suspected inflicted injury in children. Okay. You've seen a subdural hemorrhage. That's fine. Okay. Look at this. This is not a subarachnoid. It was reported by the registrar as a subarachnoid. This is not subarachnoid. Okay. This is cortical vein thrombosis. Okay?
Cortical vein thrombosis. Okay.
And that's very pathognomonic. I was hoping, which is why I was asking you, do you want anything? I always advise everybody, ask for a 3D bone recon. Okay, ask for a 3D bone recon, and I'll explain it to you. So we might miss a lot of things. I miss a lot of things. Have spent, I think, all my life looking at pediatric scans, and I still ask for a 3D because I am still not comfortable reporting it without looking at the 3D. That changes your perception. So now look at this. Can you see the extent of the fracture? Right?
Yes, it's very long.
It's very long. It's going to the sutures, right? It's proceeding, yes. It's tracking to the sutures. Okay, so this means that, and then I want you to say, once you've seen that now that I've seen the positive findings, you need to advise for an MRI brain and an MRI spine. Okay, so I will show you the MRI brain. So this was a child, we did a wrap and feed in kids to avoid it. People don't we generally do targeted, okay, unless it's the spine. For the spine, we generally give GA to the child because the child does not stay still for the spine, okay. But if I'm doing just a MRI head, we do targeted imaging. So I'm going to pick up the sequences that I want to make sure what this is, right? For me, to make sure what this is, I generally ask them, I want a DW, and I ask for an heme-onco scan, okay? So I'm going to show you these images. Always remember, this is bridging vein thrombosis. This is very pathognomonic for abusive head trauma, okay? This is abusive head trauma. There's no sort of injury that can cause this sort of a bridging vein thrombosis. And this is by shearing forces when with people or adults abuse kids generally. So their brain collides against the scalp, the cranium, and there's shearing of the cortical veins, okay? And I'll show you, this is very nice. It's not a very nice for educational purposes, but not very nice for the child. So that's your subdural that we saw, right?
Yes.
So that's a subdural, and for this I get a heme sequence, okay? So you can see, and this is known as a tadpole sign. Okay, let's do the default. So this is a default. Look at this. This is a tadpole sign. Okay? This is bridging vein thrombosis. Okay, this is very pathognomonic for abusive head trauma.
All right.
And the skeletal survey was normal, but this was the only thing. So this, and our report is generally tailored until we are sure. Okay, so we will. The report is generally like the clinical history does not match the radiological findings, or the suspected impact does not match the given history. Right, this sort of mechanism means high velocity, high impact injury. Okay, I mean shearing forces, right?
Okay.
So very good, you picked it up. Okay, but this is bridging vein thrombosis. The registrar also, he misread it and he reported this as subarachnoid. So this should trigger you once you see this. Okay.
Okay.
Now I'm going to show you Chacho Viva. So this is an X-ray I'm giving you. Describe what you find. This is just in your daily reporting file, this X-ray.
All right. So I'm presented with X-ray of pelvis of neonate, frontal projection. Here I can see some non-specific bowel gas shadows in the lower abdomen. However, there is no gas seen in the region of rectum, and I can see some. I think the left femur is short in size, raising suspicion for any rhizomelic deformity. I will like to correlate with the patient's age. And also, I'm concerned about the sacrum. I can see some decrease in the interpedicular distance, and also I can see flaring of the bilateral iliac wings and shallow acetabuli, which
How would you
are
sum them up?
concerning for
Sum it up.
underlying bony dysplasia such as achondroplasia. I will like to know the history of the patient and suggest skeletal survey for further evaluation.
So this is a patient who came to us in the ED. Okay, so this child presented to us and she said that with torticollis. Okay, so this is an 11-year-old who's presented to us in the A&E with torticollis, the neck had turned on one side, and the only history that was given to us, there's no cause, no trauma, nothing. They just mentioned that 2 months earlier, this patient had a viral infection. Okay.
Okay, these are the CT scan axial sections of head and neck region, bone window of a patient who presented with torticollis of neck.
There you have the images. I'll show you the soft tissue.
Okay.
It's downloading.
All right, in the soft tissue window, the right sternocleidomastoid muscle appears to be normal in size. There is no hypertrophy seen. On the left side, I can see a hypodense lesion noted along the uh, ear lobule. And I think
Want me
that,
to show you anything else? Do you want
yes,
to
can you
ask me?
scroll me one more time, please?
Which this one? The soft tissue or what?
Yeah, okay. I can see that there is the sir hyoid bone appears normal.
Any other sequences you want? Do you want any other
Yes, I want to see
modalities?
sagittal image if available,
Let's see.
or coronal or sagittal.
I can just show you for.
I think there is some ligamentous some calcification along the ligament interiorly along the soft tissues. I can see in sagittal, yes, over here.
Okay. There? Yeah. Do you want
Uh,
to ask for anything else?
mm, I want to okay if MRI available, I want to go with the
Okay.
MRI.
Yeah.
Otherwise, on CT, I was suspecting ligamentous calcification in the region of, I think, stylohyoid ligament. Okay, so on MRI T2-weighted sequences of fat suppressed image, I can see a hypointense signal which is fluvoid going passing medially along the parotid gland on the right
Yeah.
side.
This one? You want to see any other sequences?
Yes, can I see the stir or
This is the star, by the way, isn't it?
okay.
It's a star. This is star. I'll show you. This is star. Okay, we'll come back to this. We'll come
Okay,
back to this later. It's don't worry about it.
all right.
Come back to it. So this is a patient who this is an 11-year-old child who came to us, and the child complained of a lump in the back. Okay.
Okay.
So, you know, there's a lump in the child's back.
All right. These are the MRI images, T2 weighted images of thorax. I can see that there is altered area of signal density noted along the posterior vertebral body along their spinous process, and also I can see that there is extramedullary intradural lesion which is called pushing the spinal cord interiorly, and
Yeah. want to see any other? I just have a couple of them. You can show
Yeah.
you sagittal T1, T2 or stir.
Yes, sagittal T1, T2 and stir. Okay.
Okay. Stir.
Okay, so lobulated lesion dorsally along the spinous process, and also, can you scroll one more time to see me the? I want to see the spinal canal.
Yeah.
Okay, in spinal canal also I can see some T2 hypointensities, which could be artifactual flow void. However, the lesion is seen in the spinous process, which is a lobulated lesion. And can you see the post-contrast image if available?
There's no post-contrast.
Okay, so it's predominantly bony in origin, and my differential would include any osteoblastoma, or other differential would be of mm, less likely, it could be any ABC, aneurysmal bone cyst.
This was a 13. Yeah. So this is a 13-year-old girl who presented to the ED again, and they said that she had low oxygen saturation, she was breathless.
All right, so this is frontal chest radiograph of a child, a 11-year child with breathlessness. Um, as the patient has history of breathlessness, so I would like to zoom to look for any apical pneumothoraces. Um, I do not see any significant pneumothorax on this image. And as the child presented in A&E with decreased oxygen saturation, so and there is no gross pneumothorax is seen, and the bilateral lung fields show some perihilar opacities, and there is inhomogeneous airspace opacification noted along the left lower lung lobe. Um, with a few branching opacities. However, no pleural effusion is noted. Bilateral costophrenic angles are clear. Cardiomediastinal contour is within the normal limits. So this is concerning for underlying infectious process. I would like to correlate with the history of the patient, any history of fever, and also
No
any
history of fever.
biochemical inflammatory markers.
Inflammatory markers are normal.
I would like to compare with the previous X-ray, any if available to
So
look.
the child, we didn't have any previous imaging available.
So I would like to proceed with the low dose CT scan for further evaluation.
A low dose.
Okay, so this is CT scan axial sections, lung window of the same patient. No apical pneumothorax seen, no area of any cavity, or no gross collapse seen in these images or consolidation. Okay, in the left lower lung zone, I can see that there are dilated tortuous vascular structures noted in the region of the left lower lobe. I will like to trace it to look for the draining vessels.
What do you think this is?
As for appearances, I'm concerning for any arteriovenous malformations. And I will like to see the liver and any history for the cutaneous or skin lesions, as I'm concerned about underlying hemorrhagic telangiectasias, hereditary hemorrhagic telangiectasias. I will like to suggest workup for the hereditary hemorrhagic telangiectasias.
So this is a patient, 9-month-old child, who presented to our department and downloading this. This history was a bit very peculiar because the mother said that the child had a lump on the right temple and she could feel it moving. Okay, so can you see it now?
Yes, okay. So I'm presented with MRI brain, axial sections, T2 weighted images. I can see there is cystic lesion seen in the along the right temporal lobe. There is deficiency of the right sphenoid bone, greater wing of the right sphenoid bone, and also there is a mild proptosis of the right lobe. This is suggestive of a sphenoid wing dysplasia. And I'm concerned about the neurofibromatosis type 1. So I would like to see any underlying uh, optic nerve gliomas, which could
Okay.
be seen in the NF1, and also like to see the optic chiasm and optic nerves, and any posterior fossa, pilocytic astrocytoma. Okay, I think the optic nerve, right optic nerve is, yes, it's normal. Okay, so the bilateral optic nerves are unremarkable. Um, and I do not see any subcutaneous neurofibromas on this sequence, but my diagnosis would be of sphenoid wing dysplasia, and I'm concerned about the neurofibromatosis 1, and I will like to suggest further workup for NF1, genetic screening and genetic testing and screening for siblings as well.
Okay, very
And
good.
also,
I think
yeah,
we
like
have reached to the end of your viva,
fine,
and
like,
this
okay.
is right. You're right. This is neurofibromatosis. Show it to you. It's neurofibromatosis. There's a very good pickup. It's basically deficiency of the sphenoid wing. It's dysplasia of the sphenoid wing, right? There's all the condition over here. Okay, so now let's go to the ones that I needed to discuss with you. Okay, so this one, let's go first through this one. The child with the torticollis, right?
Yeah.
What are the causes of torticollis in children? Let's go through them, right? Okay, this I want to tell everybody, when the examiner tells you, they will give you a hint. I gave you a hint. I said this child had viral infection. Now look at the atlantoaxial joint. Is there no subluxation?
Yes.
It's subluxated. It's C1, C2 subluxation, and this as well. Look at it, which is why I stopped it here for you. Look at the distance between this and this sense in the right and the left, atlantoaxial joints,
Yes.
right? And then, I don't know if this works. I showed you the MRI. Can you see the MRI now?
Yes.
So now look at the MRI closely. And that's why I asked you, do you want any more sequences? This is inflammation ligamental inflammation. There's no calcification. And look at this bone marrow edema. Okay. This condition is known as Grisel syndrome. It happens in children who have some viral infection, okay, post-viral. And let me show to you now. So you see the edema and the bone marrow edema?
Yes.
This and this as well, right? Yeah. C1 and C2. So it's subluxated. It's causing edema. There's inflammation of the ligaments, and this is Grisel syndrome. Okay.
Okay.
This is Grisel syndrome. This was pulmonary AVM. So let me see if the X-ray is open. Oh, there's a nodule here. Look. There's no perihilar thinking. All that you were saying, there's nothing over there. There's no perihilar streaking. No, I don't even remember what you said. Sorry. There are lots of things you said. There's no ped. Look at this.
Yes, left lower lobe.
There's nodules.
Nodules,
okay? Yes.
yeah.
It's hard to pick up. I know this was noted as it's reported as a nodule, or we reported this. Somebody was reported this as pneumonia. Now, this is a very interesting case. Okay. And I think this is expansion of the spinous process, isn't it?
Yes.
So
a bony outgrowth.
So it's a bony outgrowth that's in...
Yeah, osteochondroma.
Exactly. This is an osteochondroma. I wanted you basically to ask me if this child had anything else. And I would have shown you an X-ray, skeletal survey with multiple osteochondromas in the limbs. Okay. Let me see if I have it. I'll show it to you. So this is why always remember the examiner will guide you, but you can ask for things as well, right? Because you did ask me for some things. I would look for the previous history. So you did ask me at times when you wanted to ask me, does this patient have anything else? So I would have shown you these findings if you would have asked me for this.
Yeah, multiple
osteochondromas. Yeah. It's okay, give the differential ABC, whatever. So, but just remember the gristles, the pulmonary AVM, and these things, right? And I think that's all. Do you have any questions? Sorry, we've had a very long session today because I had to rush through with SP and everything. But any questions? These are generally the pet things that you will be asked. Okay, so they will show you. I mean, this is a bit of this is more core pediatrics. These are things that you should know, working and everything. So these are things generally you would come across and you would do it, but you should know how to flag what up, when up, and how to refer it to the referring clinic physician as well. One more thing I want to ask you: be concise as well in your. You were concise. There's one more thing I forgot. When you're in doubt, always remember, it's a very key point that I've also learned. Even I have issues at times, okay, the bowel. If you're not sure about something in the exam as well, say that I would ask help from a senior colleague or a senior specialist radiologist, okay? Because UK has specialist radiologists. I would generally go to the GI one as well. And so I think that's enough. So,
thank you very much. Wonderful cases, wonderful case selection. I'm sure this not only consolidated the idea of the SPA, but also the cases which you showed were absolutely brilliant for the exam. So thank you very much, Mavish. Thank you.
No problem,
Great
sir.
session. So next session is going to be extremely interesting, and don't miss it. You can see it on the slide. This is a subject which all of you should be interested. And it's not radiology, it's more than that. This is how to cope with exam stress. And so Dr. Sumaira will conduct it. She has got a very unique CV. She is a consultant radiologist, and as well as she's a certified life coach and hypnotherapist, as well as certified in study of happiness. Stress is her subject. And basically, we know that how